these are simple cases. One is structured discussion and the other one is stimulated patient task. So I would like to know that who all want to volunteer for the first case. Any one of you. The first one is structured discussion from the antenatal module. You can just write down your name in the chat box. Okay, so Madhu wants to present the case. This is a structured discussion, Madhu. So I suppose I'm clear in my voice. Madhu, can you please unmute and tell me whether I'm clear in my voice or not so that I also hear you once and I'm sure that you are audible to me.
Yeah, audible.
Okay, dear. Okay. So I'll be starting in 2 minutes and this is your first case. This is structured discussion.
Yeah.
These are the domains.
Okay.
Okay. So this is your first question. When you want to start, just let me know so that I fix the timer for you.
No, I'll just see the first slide.
Okay, fine. Your time is over, Madhu. So
Yeah,
can you
yeah.
start? Okay, I'll start your time, dear. So here goes your first question. Yeah.
Yeah, so I'm Madhu, one of the exam candidates. I have gone through the scenario and I'm ready for the structured discussion.
Hey, good evening, Madhu. So the scenarios which has been given to you is a case of late booker who has come at 16 weeks with previous history of postpartum depression. So can you please summarize this case for me?
Yeah, so this situation sees a second gravida with previous history of severe postpartum depression, and background is 16 weeks, and 16 weeks she has stopped. She was already on Japan antidepressants. She has stopped and come for the date booking.
Okay, fine. So what further information and assessment you want to gain from this patient?
First of all, I'll introduce myself to her. I'll just confirm her name and age, and I'll just ask basic questions like, if at all, like why the late booking. I'll just inquire, and apart from that, how the pregnancy till now, any issues with any bleeding and any scan, any booking, blood and scan has been done or not, and apart from this, like when she had her last menses, cycles were regular or not, and I'll inquire about her previous pregnancy, delivery, like how a mode of delivery, and like she had previous history of postpartum depression, so all that I'll inquire, and whether she has like advised to follow, she's following with her it's a doctor, like a physician or not, and when she had last visited, and whether she has told them about her like pregnancy, like any modification. And what I can see from here that she has stopped herself. So why exactly she stopped, whether she has shown to them or not. And then any medical history, any history of high pressure, blood pressure, sugar and clot is there or not, any surgery on tummy and down below, any uh, family history of any importance, any her mother and sister, anybody had this postpartum depression thing or not, anybody in family suffering for any mental disorder, see whether she herself has a personal history of mental condition or not. Then allergy status, her BMI, her whether she takes any smokes alcohol, takes alcohol or any recreational drugs she takes or not, her support at home, and whether in last 1 month she has felt low, depressed or not. Those questions I'll ask, and how far she lives from the hospital. Then on assessment, I'll just check her general well-being, and then previous notes also I'll just want with her permission request to check her status. And also I'll inquire whether she had any history of this, whether she feels like or anybody talking to her, and any any feel of any self-harming and suicidal thoughts. Um, mm, all this I'll inquire.
Okay. So your next question is on assessment. Her GATS score is coming out to be 3. How will you proceed further with this case?
Yeah, so her GAT score is 3. So further, I'll just put her in touch with the specialist doctor, like psychiatrist, and mm, psychiatrist doctor, and this will be a and multiple MDT team also will be like involved, specialist nurse, midwife, and uh, baby and mother and baby unit also I'll put in touch. And she will be high risk pregnancy, and she will be regularly monitored, uh, and like her also with her I'll also involve her family members. So I'll tell them this high risk factors, like chances of getting like any postpartum depression also, and postpartum depression is there in her family member. Basically I'll just alert, so arrange for support, and if at all support is not, I can also arrange for her. And I'll just tell the family members about what are the like red flag signs will be there if she feels like she's controlled by anybody, talking excessively, whether taking proper rest or not, adequate fluid or not, and suicidal thought is there not. Also, all this I'll alert them, and also if possible, home visits also I can arrange.
Okay. So anything else you want to add to this? Okay. This is your next
Yeah.
question. Yeah.
Hmm. What are the yeah MBA mother and baby unit. So this is indication for if she is having some red flag signs like self-harming tendency and harming to the baby, and if excessive talking and not sleeping properly, and if it feels like she's controlled by any other person, and uh, like does he feels like those hallucination or any delusion, those signs will be there, then we need to admit her.
Mm-hmm. Anything else you want to
So
add?
and also
Yeah.
yeah, so in mother baby you need proper support, and her like adequate fluid, proper support, counselor, and regular psychiatrist, doctor, counselor visit will be there.
Mm-hmm. Okay.
And support for the baby also. Mm.
Okay. Do you have to tell something else, anything else regarding her intrapartum, postpartum period, any pre-pregnancy counselings?
Yeah, a pre-pregnancy, she's already now pregnant.
Yeah.
Next pre-pregnancy counseling, if at all next time she's planning, first of all, after delivery, she can uh, plan for this contraception, reliable contraception. She can breastfeed the baby,
Mhm.
and but like she should breastfeed. Then after that, she can take the medicine, adequate rest. And next time, if she will be pregnant, then she will be in a high risk pregnancy, and she should book early, and regularly she should follow with this psychiatrist doctor,
Mhm.
adequate and counselor.
Okay. And the medication she was on, olanzapine, what about that?
Hmm. Yeah, she's a olanzapine, so there are high risk of developing high sugars. So for
Mhm.
that, she'll be monitored,
Mhm.
and like regularly sugar in this pregnancy also her sugars will be monitored.
Okay. Okay, Madhu. Anything else you want to add to this?
No.
Okay, fine. So, you covered the station in almost, I can say, 8 minutes. Okay. And you did the station. Okay, I'll give the scenario again. So this was the scenario, dears. This is a structured discussion where a patient has come. She is 32 years with a previous history of postpartum depression in the previous pregnancy. Now she is 16 weeks and she is a late booker into her second pregnancy. She was on olanzapine, which she has stopped taking on her own. And now the examiner has a series of questions for you. So I hope this is clear. And these are the questions which I asked. Madhu, how did you do there? What do you think?
No, I didn't do well because actually not prepared also, and this is like and actually usually we're not practicing the structured discussion. That's when I should be more organized and more information. Like presenting SPT is different and SD is different,
Mhm. But you covered most of the
so more
points, you know.
practice.
You covered most of the points and most of the asterisk points you covered. And you summarize the case. We can summarize it in a better way. We can include assessment and recommendations also. I'll be telling you the model answer also. Okay, your time was over. So, regarding the information gathering, you rightly said that so she is a late booker. I would like to know the reason of her late booker. So, there can be many social factors or domestic factors behind it. And one of this is domestic violence. So, I would like to inquire about that in a sensitive manner from this patient after ensuring her confidentiality. Okay, so these buzzwords are there, which are very important to be said in structured discussion. Then she has stopped taking the
Mm.
medications on her own. You rightly said why she stopped taking and how has her pregnancy been so far, whether she has done any test up till now. Okay, and you have to offer her booking test now. Okay, so you have to tell her I'll offer her Down syndrome screening via the quadruple test and a scan and booking test. Okay, so you have to offer her now. Okay, because she is coming to you for the first time. Then you rightly asked her how has her mental condition been up till now and whether she is in regular touch with her perinatal mental health doctor. And why she stopped taking the medication is very important. You asked that. Shri Devi, can you please turn off your screen, dear? Someone has messaged in the group. Okay, so then journal information gathering, and I would like to assess her mental health status at present. That is, I would like to assess for depression by asking her Wooley's question, and I would like to assess her for the anxiety by asking her GAT2 scale questions. Okay, so so these will be the assessment part, and you rightly said the further risk assessment will be done for high for some complicated conditions like whether she is having any hallucinations, any delusions, any unusual thoughts she is having. So you rightly said that. And journal information you covered everything. You covered medical history, you covered her surgical history, family history was very important here, and you rightly asked about that also. And the journal template you followed, you asked about support, and particularly the support from the family members becomes very important here, and you asked that. Then in the you offered her examination, I suppose. Yeah, you offered her, I suppose. And then you can say at that time that I'll get, since she's a late booker, I'll get all the booking tests done at present, and also a scan done for her, and the Down syndrome screening by the quadruple test. Okay. And then further management, you rightly told, it will be in consultant-led unit, and a multidisciplinary team approach will be there, and she'll be seen by perinatal mental health team, and GAD-7 questionnaire will be put to her, and to know her further risk of, like, how if she is actually anxious, and the need for olanzapine to be started again uh, will be seen in collaboration with the perinatal mental health team. Okay, so we will go like this. And if the olanzapine has been started, so she requires meticulous weight management, and also the screening for her gestational diabetes between 26 to 28 weeks. So that olanzapine part was missing in your case. Otherwise, you covered multidisciplinary, you involved the whole team, and at around 32 weeks, the late pregnancy and delivery care plan will be formulated for her in collaboration with all those involved in her care. So that was important. That is very important. She'll be told around about the red flag sign, and even the family members will be told about the same. And she will be delivered in obstetric unit. One-to-one care will be provided to her. Postpartum period is very important for her because she is at a higher risk of developing postpartum depression and even psychosis. Prophylactic admission to mother and baby unit can be advised to her. Okay, so all these things are to be covered. You covered most of the points. You covered around 70 to 80 percent of the points there. 70% of the points you covered. Only few were left, which I'll be telling you regarding the model answer. Okay, you did a great job, Madhu.
Thank you. I'm
Uh,
not happy. One's way of talk.
yeah, a bit organization was required when you are saying the sentences.
Yeah.
Otherwise, the important points
Mm.
you have included. The risk assessment was very important here. Bringing multidisciplinary team, perinatal mental health team was very important here, and you brought that into picture. And then the late pregnancy care plan, and you have to take her through the whole of the antepartum, intrapartum, postpartum, and then the pre-pregnancy counseling. So you have to close that loop here. Okay.
Hmm. Yeah.
So, so let's see how the case will be done. So I'll just say how I'll be doing this case. Okay. Hello, I'm Gitika, one of the exam candidates. I have read the scenario and I'm ready for the structured discussion. So first question was summarize the case. So this case is regarding a 16 weeks pregnant woman who has come for booking and who has stopped her antipsychotic. She is second gravida with previous history of postpartum depression who was on olanzapine earlier. I would like to take further information from this patient and assess her mental health status, and my recommendation will depend upon the history which I have taken and the assessment of the patient. So this is the summary of the case. So now was the second question was what further information you will gather. So I will introduce myself to the patient by my name and role, and I will check her identity. I would like to know why she is a late booker, whether there are any social or domestic factors behind it, like domestic violence. While inquiring this, I will ensure her confidentiality. I would like to know why she has stopped her medications, whether she is in regular touch with her psychiatric and perinatal mental health team. How has her pregnancy been so far? Any symptoms she has at present? I would like to assess her mental health status at present. I would like to screen for her depression by asking her Wooley's question, and also for her anxiety by asking her GAD-2 scare questionnaire. I would like to know how her sleep and appetite is. I would like to do a risk assessment for her by asking her if she is having any unusual thoughts, Any thoughts of harming others? Any hallucinations? Any delusions is she having? I would like to ask her previous pregnancy details from her. How was she diagnosed with depression? What was the severity to assess the risk of recurrence in this pregnancy? Since this patient needs to be managed from henceforth, I would like to ask her the drug history apart from olanzapine, which she was on. And I would like to rule out any allergies if she have. I would like to assess her medical and surgical history also. I would like to know about her family history, which is very important here. Any suicides in the family, any bipolar disorders in the family, which further increases her risk of having mental health problem and postpartum psychosis. I would like to know about her blood group, her BMI, and I would like to rule out that she is not Jehovah's Witness. This condition is emotionally challenging situation for the patient and her family members. So support is very important here. So I would like to ask, how is the support at home? I would also like to inquire about her social factors, about her smoking, alcohol, particularly if she is using any recreational drugs after signposting, which becomes all the more important here as she is a case of mental health disorder. Then further, I would like to examine her with her permission in the presence of a chaperone after taking her consent. I would like to check her BMI, her blood pressure, and do a per abdominal examination for her. I would like to offer her blood test, scans, Down syndrome screening by quadruple test since she is already 16 weeks. Now the third question. So the GAD score has shown that she is GAD score 3. I would like to refer this patient further so that she can be assessed by the perinatal mental health team. An integrated holistic approach will be required for this patient. This patient needs to be managed in consultative unit where a multidisciplinary team approach will be given to her. Perinatal mental health team, my consultant, journal practitioner, health visitors, community midwives, counselors, pediatrician, radiologist, all will be involved in her care. Need to restart antipsychotic, that is olanzapine, will be assessed in collaboration with the perinatal mental health team. If antipsychotic is started, a stringent weight monitoring will be required for her. She may be required to be referred to the dietitian, and screening for GDM will be offered to her between 26 to 28 weeks. Since these antipsychotics, they are known to cause weight gain and also lead to gestational diabetes. At regular intervals, she'll be screened for her mental health status. A late pregnancy delivery care plan will be formulated for her at around 22 weeks. And this will be discussed with all involved in her care, including her family members. All the discussion will be documented in handheld notes with her permission. Important phone numbers will be contacted in case of emergency. Red flag signs will be told to her. Delivery will be offered in hospital, and anesthesia review will be done for her. Our aim will be for normal vaginal delivery, and cesarean section will only be done for obstetric indication. All the pain management options, one-to-one care, continuous CTG will be offered to her. The postpartum care is the most important period for this female, as she is at a higher risk of developing postpartum psychosis and depression. She may need prophylactic admission to maternal and baby unit. Joint care will provided by the GP, community midwife, health visitors, perinatal mental health team will be extended to this most crucial postnatal period. Support will be given for breastfeeding, and she'll be told about the contraceptive choices also. Again, at the time of discharge, she'll be told about the red flag signs, and the home visitor will be regularly visiting this female to look for any signs of postpartum depression or psychosis. Pre-pregnancy counseling will be offered to her before next pregnancy, since she is at a higher risk of having the mental health problem in the next pregnancy also. So this is how the answer will go. And if they ask you about mother and baby unit, so you can just say it is a specialist inpatient unit for some women with mental health problem during pregnancy or after the birth of the child. It is estimated that 4% of the women require inpatient treatment and should be admitted to specialized MBU. MBU can admit women in the late pregnancy and at any point until their baby is 1 year old. Okay, remember this point. These are calm, welcoming places that are more homely than other wards. Each mother has their own bedroom with a cot for the baby. The entrance of the unit is controlled by the staff to ensure the safety of the mothers and the baby. These units are currently funded centrally by specialist commissioning boards. And regarding the admission, the Embrace recommends admission to MBU if the mother has following conditions, that is rapidly changing mental health status, if she has any suicide ideas, if there is pervasive guilt or hopelessness, if there is significant estrangement from the infant, if there is new or persistent belief of inadequacy as a mother, and if there is evidence of psychosis. So this has been taken from TOG article, and this has been taken from NHS website. Okay, so this is how the scenario will go. Madhu, is it clear to you, dear?
Yeah, it's very clear.
Yeah, so this is how you should do your structure discussion. You should go in a flow, and once you practice it more and more, it will start coming to you, dear. Okay.
Yeah.
Okay, there are some other questions which can be asked in exam. So we all know that during the pregnancy or in the postpartum period, we are screening the mother for depression by asking Wooley's question. Please, can you show just there, just a second. The question slide. Okay. So this was the question slide. This is the question slide. Okay. So we all know that we are screening the mother during their pregnancy by asking them Wooley's question for depression. And in the question, we ask like two questions are there. And if the mother responds positively to any one of the questions, then further questionnaire is done, which is known as Edinburgh Postnatal Depression Scale or Patient Health Questionnaire 9. So this is the full questionnaire which is done if she responds positively to any one of these questions. That is, during the past month, have you ever been bothered by feeling down, depressed, or hopeless? During the past month, have you ever been bothered by having little or interest or pleasure in doing things? So if the mother responds positively to any one of these, if the woman comes late in the pregnancy, should we ask, yes, dear, we have to screen the mother with for the depression, okay? And it has to be asked. I'll be coming to that. And to screen for the anxiety, the 2-item generalized anxiety disorder scale, that is GAD-2 scale, has to be asked for. And there is a scoring which is given. Yeah, Wooley questions are to be asked. So if the score, if she responds that with the questions we are asking over the last 2 weeks, have you ever been bothered by feeling nervous, anxious, or on the edge? Or on the previous 2 years, have you ever been bothered by not being able to stop or control worry? Then, if she says not at all, the score given is 0. If she says that, yeah, several days I feel nervous, anxious, then the score given is 1. If she says for more than half of the days I feel like that, then the score given is 2. And nearly every day, the score given is 3. And when the score is 3 or more than 3 in GAD-2 scale, use GAD-7 scale for further assessment. Hope this is clear. And Ashia, the thing you were asking, at all contacts after the further contact, after the first contact with the primary care or the booking visit, the health visitor and other health professional should have regular contact with women in pregnancy and postnatal period, should consider asking 2 depression identification questions. So whenever you are coming contact with this mother, you are going to ask DIQ from her and even the GAD-2 scale. Okay, So at any time, if the mother is coming, you have to ask those. I hope that is clear with you. So the
Hello.
antipsychot, yeah.
No, hello, I'm Dr. Asia. Actually, I'm asking not for this case, for routine patient, for a patient with no any history of
Yes, dear.
psychosis.
Yes, dear.
So should we
Yeah.
come
The
because
mental
for
health
each
problems.
visit?
Yeah, that is what they are saying here. See, the NICE guideline is saying the same thing. It is saying the same thing, that any woman in pregnancy and
Yes.
postnatal period, you have to consider. Okay. So you have to ask these questions.
Okay. Okay. Thank you.
Yeah. So as I gave olanzapine I gave, so they can give you any of these drugs, okay? So they can give you clozapine, risperidone, or quetiapine, which they gave in the, it is one of the recalls, okay? They gave this drug and they asked what drug is it? So it is atypical antipsychotic drug. Okay, so it is atypical antipsychotic drug which are more selective dopamine antagonist, and they also have serotonergic properties. These atypical antipsychotic drugs, they are associated with fewer side effects than the typical antipsychotic. So we have first generation antipsychotic and second generation antipsychotic. The first generation antipsychotic drugs, they are routinely not given because they have a higher chance of extrapyramidal side effects, and they cause more of side effects, okay, in the pregnancy. That's why the drugs which we are giving, they are the atypical or second generation antipsychotics. And we all know the side effects which can occur because of these second generation antipsychotics. They can be cause sedation, weight gain, metabolic syndrome like gestational diabetes, and hyperprolactinemia. This is from Strategies. So olanzapine and clozapine has been associated with as much as 7% weight gain above the baseline with elevated triglycerides and new onset diabetes. So all these females, they should be screened for gestational diabetes between 26 to 28 weeks. Okay, and the pregnant woman should be told about the diet control and monitoring for the excessive weight gain, and it should be dealt with like in the guidance on weight management during pregnancy. So these are some of the side effects which they can lead to. With regards to the fetus, they can cause what we call it as neonatal adaptation syndrome, where the baby has irritability, the baby has insomnia, tremors linked to extrapyramidal side effects. The baby can grow small, so you may say that we will offer you serial growth scans also. Okay, and there is increased risk, as already told, for the gestational diabetes, preterm delivery, and cesarean section. However, the data is inconsistent. Okay, so there is limited data which is available regarding the teratogenic effects of antipsychotic medications. So they can give you any antipsychotic medication. Just remember this, and you should know what are the second generation antipsychotics. This is again from the talk article. What are the red flag signs for perinatal mental health, where which should be considered? So we have three red flags presentation: recent significant change in the mental state, new thoughts or act of violent self-harm, new and persistent expression of incompetency as a mother or estrangement from the infant. So these are overlapping. The indications we told for admission to MBU, these are almost the same. So remember these. Then this is from the good practice paper. They asked you what are the indication for referral to perinatal mental health team. So here we have few indications. You can remember 3 or 4 of them. Women with current illness, where there are symptoms of psychosis, severe anxiety, severe depression, suicidal tendencies, self-neglect, harm to others. Women with history of bipolar disorder or schizophrenia. Women with previous serious postpartum mental illness. Women on complex psychotropic medication regimen. Referral should be considered for women with illness of moderate severity if developing in late pregnancy or early postpartum period. So if the mother is developing moderate symptoms also in late pregnancy or early postpartum period, you should refer to perinatal mental health team. Referral should also be made for women with current mild or moderate illness where there is first-degree relative with bipolar disorder or puerperal psychosis. Women with previous periods of inpatient mental health care should be screened by the mental health services. So these are some of the indications which require referral to perinatal mental health team. This is one of the questions which they can ask in exam. So these are, I have covered most of the questions which can be asked in exams for you. So just go through the talk articles, the good practice paper, and the strategy. Okay, I hope this is clear. The station was clear to you all. Should we move to the next one? Is it clear, dears? Any doubts regarding this? Okay, great. So who will volunteer for the next station? It is a patient-stimulated task, and it is an easy task, dear. Thank you, Nandita. Who wants to do in the next station? It's an easy one, dear. Any one of you?
Can I do it, Mom?
Okay, Intezar, right?
Yes, Mom.
Okay, dear. Wait a second. I'll just put the timer on for you. Okay, so I'm starting with your time.
There is another page, Mom.
Yeah, I have 3 pages for you. Should I change the slide?
Yes, please. Next, Mom.
This has been written wrongly there. It's just the patient. Yeah, it's okay. Yeah.
There is no record for the ultrasound written, Mom.
Yeah, this is only the ultrasound report which is given. You can have a look at it. This is a scan report which
Yeah.
is given. Time is over there. Should we
Yes,
start?
Mom.
Okay, we'll start.
Yeah, please, the first page, please.
Yeah.
Hello, I am Dr. Abdul Qadir, one of the doctors in the gynae clinic. May I confirm your name and age, please?
Yes, I'm Lisa and I'm 56 years.
Okay. Hello, Mrs. Smith. Would you like to call you? Do you like to call you Lisa or Mrs. Smith?
You can call me either ways. Mrs. Smith would be fine, I suppose.
Okay. After reading your notes and the GP letter that referred to us, that you have certain concern about certain feelings of abdominal bloating of 1 year ago. I'm okay.
Yeah.
And then you are went into the GP who performed certain investigation and ultrasound, and you are coming today in order to discuss the results.
Yes, doctor. I don't know, since 1 year I'm having this bloated feeling in my tummy. GP has done a blood test and a scan for me, and I really want to know the results. What do they say?
Yes. Okay. If there is any other symptom accompanied with that, this feeling of abdominal bloating starting 1 year ago, any accompanying symptom?
Yeah, actually, the bloating started around 1 year back, and I can feel that my tummy is growing large. And my clothes, they are from my tummy side, they are getting tightened, and otherwise from my arms, they are getting loosened up. I think I'm losing weight too. So all these symptoms I'm experiencing recently, but this bloating is there since
It
one
is
year.
yes. Is this accompanied by pain? Any pain all
And
over abdomen or anywhere else?
yeah, it's just a dull aching pain which is there. Otherwise, I'm okay with it.
What about your appetite, ma'am?
Yeah, it has decreased. I've recently noticed that it has decreased.
But about the amount of body weight decreasing, is it suitable to that decreasing your appetite, or you notice much more decrease in weight?
I know, my appetite has decreased, might be because of that I'm losing my weight, but I have definitely lost 4 to 5 kgs of weight in the past 1 year.
Okay. What about if there is any bleeding from any orifice in your body?
No, bleeding is not there.
What about your waterworks? And what about your intestinal works? Or
Yeah, they are fine. My bowel movements, they are fine, and my waterworks are also fine.
yeah, yeah. Well, okay. I think Mrs. Smith, you has gone into your changes.
What, what do you mean, doctor?
Uh, you have gone through your changes, mean that your period has been stopped.
My periods have stopped 5 years back, and yeah, they have stopped.
Okay. Do you have any other complaint or any other medical condition you receive treatment for or you see your GP for?
No, I don't have any problem otherwise. I'm fit and fine.
Do you perform any surgery before in your tummy or down below?
No, never.
Are you allergic towards anything
No,
or any drug?
no,
Do you smoke,
no.
drink alcohol?
Occasionally, just on parties.
Yeah, I beg your pardon. Sorry. Any recreational drugs?
No, doctor.
Okay, nice to hear that. All right. Are you updated with your cervical screening?
Yeah, I'm very much up to date with it, and all my smears have been perfectly fine.
Yeah. Uh, do you have children, or do you get pregnant before?
No, I tried to conceive, but I couldn't have children. There was some problem with me, but after we tried for 4 5 years, but I don't have any.
Okay. Do you have any concern about your family history? Do you have any family history in the family of similar condition like you?
No,
Or I'm sorry, if any one of your family member having tumors in their abdomen, in their colon, breast, they develop before blood clotting in the legs or lungs.
no.
Okay, thank you for sharing those information with me, Mrs. Smith. Coming coming to the and if you please, I like to examine you in the presence of a chaperone to measure pulse, blood pressure, temperature, as well as height weight ratio. Also,
Yeah,
try to examine your tummy.
yeah. Oh, it's okay, doctor. I can understand, but uh, uh, can you please tell me, because my husband just got operated for the heart surgery, and I really have to take care of him, and I need to go home. So, can you tell me the reports, please?
Yes, of course. Yes, of course, Miss. I'm really sorry about what happened to your husband, and I really appreciate that you take care of him and that you are worried about him. And I hope he will be fine and in very good health.
Oh, that's so nice of
So,
you. Thank you.
coming to the
Yeah.
Okay, coming to the investigations done, the GP has been done a blood investigation called CA125, which is a certain chemical in your blood that we will do when we are suspecting that there is something upon something inside your tummy or specifically inside your ovary.
Oh, what does
Do you
that
follow
mean?
me, Mrs. Smith?
You mean to say
That is to say, Yeah, actually, this is part of the investigation. When the patient come to complaining of bloating in an abdomen, we do this chemical material in your blood. We call it a tumor marker. That is
Mhm.
to say, it suspects that there is certain abnormal cells present, or there is certain abnormally functioning organ inside your tummy, and in here in your condition, it is about your ovary.
Oh, do you mean I have a cancer?
No, this is not what I mean. This means that we have
चलो
certain
15 मिनट चलो 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 हो जाएगा
Please, everyone, mute yourself.
that there is something
Yeah.
that there is something abnormal or abnormal growth inside your ovary. And actually, this is complemented by the ultrasound, the transvaginal ultrasound that GP has done, which reveals that your right ovary is enlarged, and this enlarged ovary containing a multilocular mass, multilocular mass
What is meant by
that is
multi-local?
really
Mm-hmm.
that is to say, there is a mass inside your ovary formed of multiple locules or multiple fluid-filled spaces.
Okay,
It's
so
that is about 13 centimeter by 13 centimeter, which is not. This is not the usual picture of your ovary at your age.
what does that mean? What is the diagnosis like? What do I have?
Yeah, this picture together with the tumor marker level inside your blood it is mean that there is a possibility that there is an abnormal cells in your abnormally functioning cells inside your ovary.
Mm-hmm.
And by a certain equation, by certain equation, taking the level of the tumor marker CA125, the ultrasound picture and its criteria, and together with your age, we calculate the number taken from it, so that by a certain equation, here in your condition, it is above 250.
Mm-hmm.
So that this is highly suspicious of a presence of a tumor inside your right ovary.
Oh,
I'm really sorry to tell you that. I'm really sorry, and I hope you forgive me
but
that I'm telling you such
what I am supposed to
bad
do now,
words.
doctor?
Or
I have to take care of my husband. Time is over there. You
yeah,
can continue. Yeah.
I'm really sorry, but I have to refer you as soon as possible, within 2 weeks from our meeting today, into a group of doctors that is highly specialized in the tumors of the ovary. We call it a multidisciplinary team, or of doctors, of oncology doctors. Oncology doctors is that doctors which are specialized in tumors of the ovary, so that they will assess your condition and they give us the final diagnosis and the final management with that. Of
So,
course, I will give you a patient information leaflet about ovarian tumors, especially about ovarian tumors, and I will give you also the contact number of supporting groups that having the same condition, which could benefit from their experience.
Okay.
And then I will arrange with you another appointment with our consultant present after we have reached the final diagnosis from the oncology team, in order to discuss the further management after that.
Okay.
I'm sorry. Is this sounds okay with you, Miss Smith?
Yeah, okay. It's fine. I'll just have a word with my husband and I'll come back. So should I can I delay it for a month or so?
No, no, I'm sorry. I'm afraid not, Miss Smith. For your sake and for the sake of your health, we have to refer you immediately, as much as possible, as soon as possible, most probably within 2 weeks maximally. So please make your decision rapidly and inform us. I will give you my contact number. You can contact me, ma'am, at any time. Okay, it's in order if you have certain address or certain developing symptom or complaint again. Okay.
I'm very feeling anxious, doctor. Am I going to die?
No, please don't say that, Mrs. Smith. No, don't say that, because actually we are still in the beginning of the situation, and thank God we now discover it early. So when we are going to repair and we'll manage it rapidly, of course there is very good very good chance to be in the very early beginning, so that it will be easy to be treated and to receive the suitable treatment. Of course, no one who said when we are going to die or are going to live, but we have to move forward in order to deal with the condition as soon as possible.
Okay, it's fine. Okay.
Do you have any more concerns, Mrs. Smith?
No, doctor.
But I want to assure you, Miss Smith, at the end, that we are all here together, the whole team, my consultants, the oncology team, the midwife, the specialized midwife nurse, everything will be at your service, and we will do whatever we can in order to reach a suitable plan for you.
So, doctor, you have your scan, my scan with you. Can you tell me the stage of the cancer, please?
Actually, this is not possible through the scan, Mrs. Smith. The staging of your condition is through surgery.
Okay.
Because surgery will give us the final diagnosis, whether it is totally malignant or not, and also the staging and the extent of the tumor inside your tummy. Of course, there are certain new modalities of the scans like MRI or CT may give us an idea, but the surgical staging remains the cornerstone for reaching final diagnosis of the condition.
Okay, fine. Okay.
Especially when we remove the tumor and expose it to examination in the lab to know the type of the tumor and its aggressiveness.
Okay, doctor, that's fine. Okay, thank you so much.
Okay, do you have any more?
No.
Thank you, Miss Smith.
No.
Thank you.
Thank you. So, dear, how did you do?
I don't know, ma'am, but I was mumbling. Somehow, I wasn't feel confident. I don't feel that I'm fully confident with myself and I'm talking.
Okay.
And I think I didn't break the bad news as it should be.
Okay. What else? The information gathering was almost complete, but you really have to work on your time management there. You really have to work on it. The same information gathering you should be able to collect within 3 to 3.5 minutes. Okay. Otherwise,
Yes,
you
ma'am.
won't be able
Yeah.
to tell her anything after examination or just breaking the news. The further management time was totally after 10 minutes. Okay. And there effectively you will be getting 9 minutes there. Okay. So
Yes, ma'am.
try there, because it becomes so much important. Time management really becomes very important. Almost all of the
Yes, ma'am.
candidates, they are doing the similar thing. Okay. And what you are saying, others are also saying the same thing. The main thing is whether you are able, how much you are able to cover in those 9 minutes. Okay. That is very, very important. You asked me about the information gathering. That was perfect. You offered me examination when I thought that the time is less. I told you that please tell me my reports. You told the reports, but try using short sentences, try using crisp sentences so that you are able to finish your station. Okay?
Yes, ma'am. Yeah.
Because you have to refer her to MDT, you have to involve the counselors, you have to tell her about the management. She'll be also be having, the role player will also be having some questions to be asked from you, and those carry marks. So if you won't be able to finish your station, then the role player won't have any time to ask those questions from you. Okay. So it becomes very
Yes, ma'am.
important to finish your information gathering within 3 to 3.5 minutes. And it is easy.
Yes,
It's
ma'am.
easy. It'll come with practice. You have greatly reduced it down further. Because I've been listening to your recordings, you have really greatly reduced it, but try to reduce it further here.
Yes,
Okay?
ma'am.
Just keep on
And
working
what
on.
about, ma'am?
Yeah.
What about my answers upon her questions
Yeah.
regarding applied technology?
The answers were perfectly fine. I'm going to die. You told her we can't, we are there with you. Nothing can be predicted. And, but we have to take things from here forth. And when I asked about the staging, you told that it is a surgical staging. That was all absolutely fine. And when I told that whether I can just postpone this surgery, you rightly told me that we can't. Otherwise, the staging will be up. The cancer will be upstaged. So all those answers were right, dear. But those will carry marks only when you are able to answer those. You have time, and you have to create that time for yourself. Right?
Is it right, ma'am, is, is it right, ma'am, to talk to the patient about the equation of the malignant index?
No, don't tell her regarding RMI score. Just tell her a scoring is done based on your blood test, which has been done, your scan reports, and depending upon your menopausal status. And if the score comes out to be more than 250, we normally refer these kinds of patients to multidisciplinary team. That is a group of specialized people, which include cancer surgeon, cancer physicians, the counselors, the Macmillan nurses, and the sonologists. They all sit together, they formulate the management plan. So with this score,
Yeah, I
we will.
said much jargon, ma'am. I said jargon words like oncology team. She doesn't know what about oncology.
Yes,
I said yes.
yes. You use,
Specialized in cancer treatment. I should say that. Yes,
yeah,
and Macmillan nurse.
Macmillan
Yeah, yes,
nurses.
ma'am.
Okay. So all
Yeah,
these things, and we will offer you a CT special scan to look how far this tumor is there, whether it is just confined to your ovary or it has spread. So a special scan will be offered to you before your referral. This is CT scan of your tummy, and once this is done, to get all your reports will be forwarded on urgent referral pathway within 2 weeks to the group of specialized people who will be seeing all your reports, and they will be formulating the best management plan for you. Okay.
yeah, yes,
Mostly
yeah,
the treatment involves a surgery in which we normally give an up and down cut on the tummy. We take the womb, the tubes, the ovaries, a fatty layer of tissue around your womb out, and also the nodes which drain this area. And we send all these,
yeah,
and we send all these things to the lab for further evaluation. Some females may require further treatment after surgery, which we call it as a chemotherapy. These are in the form of medications which are given through cannula inside in your veins, in your blood vessels. Okay. And normally we give 6 cycles of these at 3 weekly interval. These medications can sometimes cause you feel nauseated, make you feel sick, cause you hair loss. And we can give you medications to deal with your sickness at that time. This is too early to decide at present. Okay, so this is how you have to tell
But
her,
ma'am,
yeah.
Yes, ma'am, you are absolutely right. But I think when I told her we refer her to the oncology team, I thought that that team, after examining her and after examining investigation, they will tell her that. I don't know. I'm going to tell her before, or I will tell her that I will tell you, and there they will tell you.
Just tell her they will be formulating the best management plan for you. Mostly with this situation, the treatment involves a surgery. Okay.
Yes, ma'am. Yeah, I mean because of the time, ma'am.
Yeah, because of the time. See, the time you have to cut down on your information gathering. That took a long time there. That took 6 minutes, six
Yes.
and a half minutes.
Yeah.
Once you will cut down your information gathering, you will be able to finish all this.
Yes, ma'am. Thank you very much, ma'am, for allowing me this opportunity. Thank you.
Thank you, dear. Thank you. So we will just see how the station will go. So if sometimes the patient and you didn't fix the agenda also, dear, so try to fix the agenda. Sometimes, am I not audible? Am I not audible?
You are audible, ma'am.
Okay.
No, you are audible, ma'am.
Okay, Rajni, please check your net, dear. And Hafsa, I will tell you the answer just after this station, dear. Okay. So let's see how I'll be doing the station. Hello, I'm Dr. Gitika, one of the doctors in the clinic today. May I confirm your name and age? Hello, doctor. I'm Lisa Smith and I'm 56 years old. And how do you want me to be addressing you? You can call me Lisa, doctor. Lisa, call me Gitika. Lisa, I understand that you are suffering from bloatedness in your tummy since 1 year. And the GP has done some tests for you and you're here to discuss those reports. Is this correct? Yes, doctor. Okay, Lisa. Lisa, would it will be fine that if I ask few questions from you before I discuss your reports and further management care plan, which is safe and acceptable to you? No, doctor, I'm feeling really very anxious. Actually, I have left my husband at home and I want to know the results. I'm really anxious about my results. That's absolutely fine, Lisa. So, Lisa, are you alone here today? Yes, doctor, I'm alone. Do you want my staff to be with you once I'm discussing the reports with you? No, doctor, what happened? Is there something concerning? It's okay, you can discuss the reports with me. Lisa, do you have any idea about the reports? No, I don't have any idea, doctor. Lisa, I've confirmed that these are your reports by your name and NHS number. 2 tests were done for you. One was the blood test and the other was the ultrasound scan. The blood test was done to see for a protein which has come out to be raised in your blood. Normally, this protein can be raised in number of conditions, but at your age, we are more concerned about for the cancer of the ovary. So the normally the value is less than 35, but in your case it is around 700. Also, the scans shows that there is growth in your right ovary, which is suspicious of a cancer. I'm so sorry to give you this news, Lisa. I know that this has come as a shock to you. Are you fine? Do you want me to continue with the conversation, or we can book another appointment after some time? No, doctor, I'm fine. Uh, how to take the things further, doctor? I'm very upset. I have to take care of my husband. Yes, I totally understand that. And that is really appreciable that you are so much worried about your husband. Before I discuss your management option further and we come to a management plan which is evidence-based, safe, and acceptable to you, can I ask you a few questions so that I can address your concerns in a better way? Yes, doctor. So, Lisa, can you tell me the symptoms, the problems you are having? Yes, doctor, I'm having bloated sensations since 1 year. I'm also feeling that my tummy is growing big. I've also lost 5 to 6 kgs of weight. Okay, any changes in the appetite? No. Any problems with the water work? No. And bowel opening? No. So, Lisa, are you still having your periods or they have stopped? No, doctor, they stopped around 5 years back. And are you on any hormone replacement? No, doctor. Are you up to date with your cervical smears? Yes, I'm up to date with it. What about children's? Do you have any child? No, unfortunately, I had subfertility and I tried to conceive for a few years, but I couldn't bear a child. Okay. And are you on any long-term medications? No. Any allergies do you have? No, doctor. Are you seeing your GP for any other medical reasons? No. Any family history of cancer of womb, breast, or ovaries? No, doctor. Lisa, are you aware of your weight to height ratio? Yeah, it's 26. And your blood group? It's B positive. Few questions about your social habit. Hope you don't mind, Lisa. Do you smoke, take alcohol, or any recreational drugs? I can see that you are alone with your husband and taking care of him. So how is the support? If the need arises, we can provide you support from NHS, Lisa. Please feel free to ask. In the last few weeks, how have your mood been? I would like to, anything else you want to add to this, Lisa, which you think is important and I have forgotten? I would like to examine you now with your permission and the presence of a chaperone. I'll ask my midwife, I'll ask my nurse, sorry, it shouldn't be midwife over here. I'll ask my nurse to see your pressures and your heart rate. I'll be doing a tummy examination for you to look for mass, any painful area, any swollen glands. I would like to offer you a speculum examination. This is with the help of a small instrument to look at the condition of the neck of your womb, and also an internal examination to look for the size of a mass. Is it okay with you? Yes, doctor. Now coming to your concerns, Lisa. So normally with these reports in hand, we normally calculate a score for you. This score is based on the test reports, the scan, and your menopausal status. In your case, since the blood report of a protein is already 700, so it is more than 200 in your case. So we'll be offering you a special scan to look at your tummy. This will tell whether the growth is just confined to the ovaries or it has spread elsewhere. With all these reports in hand, your case will be referred to a team of specialized people, which we call it as multidisciplinary team. This includes cancer surgeon, cancer physicians, counselors, sonologists, Macmillan nurses, and the consultants. Based on your reports, they will be formulating the best management plan for you. All this will be done within 2 weeks from the date of your referral to us. Mostly the treatment involves a surgery which involves giving an ups and down cut on your tummy, taking out the womb, tubes, ovaries, layer of fatty tissue, and nodes that drain these areas. These tissues will be sent to the lab for examination. What is the stage of my cancer, doctor, if it is there? Though, Lisa, by doing CT scan, we may get a rough idea about how far the cancer has spread, but the final stage is only clear after surgery. Depending upon the stage, you may require something we call it as chemotherapy. These are the medications which are given through cannula inside your vein, inside your vessel. Normally, we give 6 cycles at an interval of 3 weeks each. They may cause hair loss, make you feel sick, nauseated, but we'll be giving you medications for this. You will be requiring long-term follow-up. Am I going to die, doctor? Please, Lisa, don't lose hope. We are there with you in this journey of care. Survival depends upon many factors. Stage, how much abnormal the cells are. How do you respond to the treatment? Overall 5-year survival rate of this cancer is 45 out of 100. Can I delay the surgery, doctor? I have to take care of my husband. For us, Lisa, patient safety is our utmost priority. Delaying surgery may upstage your cancer, so we will not recommend that for you. But definitely, we can provide you as much support as we can from the NHS. So if it is fine with you, Lisa, I would ask my nurse to arrange a CT scan for you, following which urgent referral to specialized team will be made. Once the decision has been made to treat, you will be offered surgery within 31 days under NHS pathway. I know that this is a very distressful condition, Lisa. If you wish, I can offer counselors also to you. I'll book another appointment of yours with my consultant and give you written information about your condition so that you can make an informed choice. There are many support groups by the name Overcome and Macmillan support groups. These are the 24 hours helpline number. In case you have any problem, you can contact us at any time. How does that sound to you, Lisa? Anything else you want to know from me? No, doctor. Thank you for your time, Lisa. If you are okay, I'll ask my nurse to make arrangements for the CT scan. Okay, doctor. So, Intezar, this is how the station goes there. Hello?
Excellent, ma'am. Excellent.
Yeah. So you can just listen to it 2-3 times and you can practice on your own. Okay? So this is covering all the questions.
Yes, ma'am.
And I suppose this has covered all the answers also, which the queries you might be having in your mind, that how we are supposed to answer. Okay?
Thank you, ma'am. Thank you very much.
Okay, dear. Okay. So this is very, very important, the NHS referral pathway. The NHS constitution has been set, which says that the following rights should be given to the patients with cancer. A maximum of 31 days wait period should be there from the decision to treat is made to the first definitive treatment. So once the MDT says that, yes, this treatment has to be given, you have to treat this patient, you have to offer her surgery within 31 days. A maximum of 31 days wait for subsequent treatment when the treatment is surgery. Once you have given the surgery and you want to give chemotherapy now, it should be given within 31 days. A maximum of 31 wait period for subsequent treatment when the treatment is a course of radiotherapy. So any subsequent treatment should be given within 31 days. A maximum of 31 days wait period for subsequent treatment when the treatment is an anti-cancer drug regimen. Maximum of 62 days wait period from urgent referral for the suspected cancer to first definitive treatment for all the cancers. So once the GP is referring you with the suspected cancer, definitive treatment for that cancer should be given within 62 days. A maximum of 62 days wait period from referral from the NHS cancer screening to the first definitive treatment for the cancer. This is not that important. The last is also important. The maximum of 2 weeks wait to see a specialist for all patients referred with specific cancer symptoms. Okay, so once the GP is referring you, the patient should be seen by you and MDT within 2 weeks. This is the NHS referral pathway. You all should be aware of. This you can tell in MDT letter teaching also. This you can tell in cancer stations also. This we all know how is the pathway of ovarian cancer goes. So if the woman comes to GP and the GP assesses the symptoms, if on examination the GP finds that the patient has ascites or any mass, they are directly referred to the secondary care. Otherwise, if these are not present, but only the symptoms are present, then the tests are offered in the primary care. And if there is suspicion of ovarian cancer based on test, then the patient is referred to the secondary care. From the secondary care, when the diagnosis is confirmed for ovarian cancer, then the patient is reviewed by MDT, and the confirmation of diagnosis is there. The surgical staging is offered and tissue diagnosis by histology if considering neoadjuvant chemotherapy. So depending upon the stage, you will treat the cancer. Again, women who are referred to secondary care with suspected ovarian cancer, if the tests have not been done in the primary care, you offer them CA-125 and pelvic ultrasound. If the female is less than 40 years, then you offer them additional tumor markers, that is alpha-fetoprotein, beta-HCG, and LDH. You calculate the RMI score. If RMI score is 250 or more than 250, refer to specialized MDT. If the ultrasound serum CA-125 or clinical status suggests ovarian cancer, we will perform a CT scan of the pelvis and abdomen and thorax if clinically indicated. Do not offer MRI routinely. Offer information on ovarian cancer, including psychosocial and psychosexual issues. So this is, yes, dear. This has been taken from strategy. So this chart is so much important, you all know. So a postmenopausal ovarian cyst, if the cyst is 1 centimeter or more in size, we will offer the postmenopausal female CA-125 transvaginal scan with or without transabdominal scan and calculate her RMI score. If the RMI is less than 200, there is low risk of malignancy, and we will see what type of cyst is present. If the cyst has all these following criteria, that is, the cyst is asymptomatic, it is a simple cyst, it is less than 5 centimeter, it is unilocular, unilateral, then offer conservative management. However, if the cyst has any of the following features, the cyst is symptomatic, it is non-simple, it is more than 5 centimeters, it is multilocular or bilateral, any of these following features, then consider surgery, and the surgery is laparoscopic bilateral salpingo-oophorectomy. If the score is 200 or more than 200, then a CT scan abdomen pelvis is done and further referral to gynae oncology MDT review is made. If the MDT review shows that there is high likelihood of ovarian malignancy, in that case, offer laparotomy with full staging procedure by trained gynae oncologist. If the referral to gynae onco MDT review, if the review has been done and it shows low risk of ovarian malignancy, then in that case, laparotomy with pelvic clearance, that is TH with BSO, with omentectomy and peritoneal cytology is done by a suitably trained gynecologist. So this chart is very, very important, yes. So this was regarding today's session. I hope the session was helpful to you. Please do drop your feedbacks, dear. It'll really keep us going in a flow and keep us motivated. And just to tell you that all the groups are full now for Raise Academy, but we have one-to-one session with Dr. Rashmi and with me. In case any one of you wants to join us, they can join us as one-to-one session. And thank you all for listening. Yeah. Who is that?
Thank you, Dr. Arora. This is Anila Kamil here.
Okay.
And I just wanted to ask you, thank you so much for your session, which was so concise and to the point and very informative. And I just wanted to know, should we be asking every patient, have you vaccinated yourself with COVID-19? Are you bothered by some symptoms at present? Should that be mandatory with every patient?
I don't think
in
so.
the pandemic situation?
I don't think so, because I just gave the exam and I didn't mention in any of the stations, frankly speaking. So the pandemic, sometimes the cases are increasing, sometimes they are decreasing. So I didn't ask. Frankly speaking, I didn't ask. So I don't think so that you have to ask in each and every case. But yes, in antenatal,
Okay,
yeah,
congratulations. Congratulations.
thank you. Thank you, dear. Thank you so much. So this was regarding me. Rashmi, are you there? You want to say something?
Yeah, yes, Geetika, I'm here. I have listened to your session and it was a wonderful session. And the cases discussions, they were just too good and the students have done well. Just some modifications which are required, which you rightly guided them. So I hope Madhu and HSR, so you'll keep a note of that.
Yeah.
And yes, we are full with the August batch, and currently we are not doing any other extended course, but the requests have been pouring down. So we may plan a crash course somewhere close to the exam, which will be maybe some 3 or 4 weeks course like that, and there will be a marathon course again. So currently there won't be any other extended course. So we are full with the batches. And sorry about that if like few requests had come, but it was only on the first come first serve basis. So we are full with the current batches as such. So as Geetika rightly said, so we have the one-to-one. So if anybody interested, so contact any one of us. So we'll be happy to do that. And all the best. Keep studying. The practice must go on. Make sure you're doing n number of stations, and the practice books are there. So just keep. Sending those voice notes. So we are doing the repeatedly I'm doing the Oxford and Geetika is doing the Justin Coney's book. So keep practicing in the groups, and the more you practice, the more fluent you will become. So trust me on that. The sentences will just come out from your mouth. You will be saving seconds at each and every point. And that is so important in MRCOG part 3, that you're conveying everything correctly in the precise time and finishing the station. That is really important. Okay. So yes, Ketika, it was lovely having this free session with you, and looking forward to more from our Rails Academy. Yes.
Yeah, definitely, definitely. So thank you everyone for joining the session, and wish you all the good luck, and stay safe. Good night to all, and thank you, dears. Thank you, Rashmi, for letting me do this session. Thank you, dear.
Thank you, Geetika. It's wonderful having you as a team. Thank you.
Thank you.
Bye. Good night, everyone.
Good night. Good night. Good night.